My name is Marla Bergwager. I serve as the Executive Director of the Gateway Geriatric Education Center, located in the School of Medicine at St. Louis University. I also have the honor of serving as the Program Director for the Geriatric Workforce Enhancement Program Initiative. I'm a faculty member in the St. Louis University School of Social Work. St. Louis University has received funding from the Health Resources and Services Administration for 30 years to provide geriatric education to health systems and community organizations, as well as professionals and the community. Our current project, the Geriatric Workforce Enhancement Program, emphasizes delivering education to future and practicing healthcare providers so they may help older adults age successfully. We also provide education to support care partners, including those who provide care in formal settings as well as those caring for a loved one. Our goal in creating this video is to introduce you to the age-friendly health systems concepts and the 4Ms framework. You'll learn more about the 4Ms framework, but by way of introduction, the 4Ms of geriatric care focus on what matters to the older adult, mentation, mobility, and medication. We will return to a deeper exploration of each of these areas. Secondly, we want to offer support for those organizations interested in transforming their acute care, outpatient, and/or post-acute care settings into becoming age-friendly health systems. Why is the age-friendly health system model needed? Becoming an age-friendly provider is critical as the numbers of older adults continue to rise. Having healthcare professionals and organizations understand the needs of this growing population is a strategy to more effectively and compassionately serve older adults and their care partners. In addition to the rise in the number of older adults, aging-specific knowledge and skills are needed to address such issues as barriers to communication with older adults and their care partners, challenges associated with coordination of care and transitions of care, and a need for meaningful, non-pharmacologic interventions. The John A. Hartford Foundation, in collaboration with the Institute for Healthcare Improvement and the Catholic Health Association of the U.S., developed the Age-Friendly Health System Framework as an approach to address the needs and challenges of aging. Since the launching of the Age-Friendly Health System Initiative, over 2,000 healthcare organizations in the U.S. have been designated as age-friendly health systems. Specifically, the goals of the age-friendly health system movement include following an essential set of evidence-based practices, causing no harm, and aligning with what matters to the older adult and their care partners. As promised, I want to expand on the 4Ms framework. The age-friendly health system model is built on a framework known as the 4Ms, which entail what matters, involves knowing and aligning care with each older adult's specific healthcare outcome goals and care preferences across all settings of care, including but not limited to end-of-life care. In essence, asking the older adult what is important to them, whether it be for that visit or to achieve their desired quality of life as they age. Medication. If medication is necessary, use age-friendly medication that does not interfere with what matters to the older adult, mobility, or mentation across all settings of care. Mentation. Prevent, identify, treat, and manage dementia, depression, and delirium across settings of care. Lastly, mobility. Ensure that older adults move safely every day in order to maintain function and to do, again, what matters. The 4Ms framework is not a program, but a shift in care and is implemented together as a set of evidence-based elements of high-quality care. Your organization may already be including some of the 4Ms, which can become the foundation on which you develop plans for a transformation of your organization. This video will highlight the age-friendly health movement initiatives in which our Geriatric Education Center is involved. First, you will hear from Dr. Angela Sanford, Interim Chair of the Division of Geriatric Medicine, to gain her perspective on the need for healthcare organizations to be age-friendly and strategies that she uses to promote age-friendly practice.
My name is Angela Sanford, and I am the Interim Division Director for the Division of Geriatric Medicine at St. Louis University School of Medicine. A geriatrician is a physician who has done specialized training in the care of older adults. I only see patients who are older than 65 years of age. As a geriatrician, my work is very diverse in that I see patients in clinic, in the hospital, in the nursing home, and in assisted living facilities. Every day in my work, I see firsthand why it is so important to develop a healthcare system that is aging-friendly. What is the purpose of an aging-friendly healthcare system, you ask? There are no set established definitions, but there are perspectives and opinions. In my work with older adults, I frequently hear that aging in place is one of the most important aspects contributing to their quality of life. Most people desire to live in their own homes for as long as possible and would also like to maintain the ability to care for themselves for as long as possible. Therefore, I place these, quality of life and promotion of aging in place through maximizing functional ability or the ability to care for oneself, to be the central features of an aging-friendly healthcare system. To further promote quality of life and aging in place, the aging-friendly healthcare system also needs to focus on how we can safely reduce hospitalizations for older adults and improve transitions of care across the geriatric care continuum. Finally, an aging-friendly healthcare system both identifies and supports end-of-life preferences and goals, because these also greatly contribute to overall quality of life. We can achieve all of these important geriatric care principles through the development of an individualized treatment plan for each older adult. Why do we need an aging-friendly healthcare system? The growth rate for those over age 65 has tripled during the 20th century, and older adults are the biggest utilizers of our healthcare system. We have reached a unique time in the history of the world in that the year 2035 marks the transition point in which there will be more people older than age 65 than there will be people less than 18 years of age for the first time. There will potentially be more non-working adults than working adults. There is a great concern by many experts that our healthcare system and society infrastructure are not ready for this shift. With the rapidly increasing geriatric population worldwide, there is a great need for the development of aging-friendly healthcare systems that are accustomed to the challenge of providing care to complex geriatric patients. Unfortunately, there is a shortage of geriatricians in the workforce, and very few older adults get to see a geriatric specialist. Thus, much of the implementation of aging-friendly healthcare systems will fall to primary care physicians and other specialties. One of my focuses is to educate and train the rest of the physician workforce and interdisciplinary team on best management principles. Specifically, our training focuses on the diagnosis and recognition of common geriatric syndromes, minimization of polypharmacy, dedicated discussions on end-of-life care goals, and the central role of the interdisciplinary team. A large focus is also educating future healthcare leaders in all of these principles. One of the initiatives of an aging-friendly healthcare system is to identify and diagnose geriatric syndromes. In 2015, the Rapid Geriatric Assessment, or RGA, was developed at St. Louis University to encourage screening in the geriatric population despite time constraints faced in busy healthcare settings. This is a brief screening tool which can be administered in 4 to 5 minutes by office personnel or any member of the interdisciplinary team. It's been validated in various care settings. The RGA identifies 4 important geriatric syndromes that can greatly influence quality of life and aging in place. These syndromes are frailty, weight loss, sarcopenia, which is loss of muscle, and cognitive impairment or dementia. In conclusion, with the rapidly increasing older adult population, there is a great need to develop a healthcare system that is accustomed to managing the needs of these complex older adults while focusing on core principles such as quality of life and successful aging. We can work together to develop aging-friendly policies and procedures which govern healthcare at the local, state, and federal level.
Next, you will see an age-friendly health system in action here in Missouri. Perry County Memorial Hospital in Perryville, Missouri, began their transformation in 2015 to become an age-friendly health system which continues to flourish today.
Our real journey towards an age-friendly health system started in 2014 after learning about a program called Cognitive Stimulation Therapy, or CST. At a conference at St. Louis University, Dr. John Morley was giving a talk on dementia. And I approached him and asked him if he would be interested in coming and doing a similar talk to our physicians here, our medical staff. And it happened in that conversation telling him that we were doing CST here. He approached us about becoming a partner in the Geriatric Workforce Enhancement Project. So he and Dr. Bergweger came down, met with our administration, us, and we formed that partnership. One of the first things we did was to integrate the rapid geriatric assessment into our EMR, both in the hospital and our outpatient clinics and our doctor's offices, and into our Medicare annual wellness visit. So basically just being able to have a rapid way of identifying risk factors for older adults and then putting interventions in place. When we assess for CST, it's about a 2-hour assessment. So it's a full interdisciplinary professional healthcare team. So we have the speech therapist, the occupational therapist, and myself. And we also meet with caregivers. So we really want to get a feel for what's going on. And at that time, we're also looking for reversible causes of dementia. So we're looking at things like, we're looking at their hearing, their vision, we're doing a depression screening, we're asking about their sleep, because all of these things can exacerbate the symptoms of dementia. And then also just really talking to caregivers about the problems that they're seeing. And from there, we make a determination whether or not we feel like they're more, if it's more an advanced dementia, with more some of those behavioral things and caregiver struggles, then we may put them into our COPE program.
So COPE stands for Care of Persons with Dementia in Their Environment, and this program is intended for people living with dementia and their care partners. This program is really designed for people living with moderate to severe impairment, and it's completed in the home of the person living with dementia, so that we can kind of get a better idea of how their day-to-day life is and how things, the environment can impact their behavior. The care team that will be implementing this program is a social worker, an occupational therapist, and a speech therapist. Throughout the program, we will keep in touch with the primary care physician of the person living with dementia. The main goals of this program are to reduce challenging dementia behaviors, maintain their functional disability, and that happens through care partner education, training, and support. There are 3 phases to this program. That is the assessment phase, the intervention phase, and the generalization phase. Assessment phase is where we assess the person living with dementia, their functional cognitive level. We look at their functional mobility in their home. We look at how they participate in self-care tasks. And all throughout that assessment, we are watching their problem-solving skills, their initiation skills, and then we also meet with the care partner, and then we learn from them what their biggest challenges are in the day-to-day routine of caring for that person living with dementia. And we provide education to them, resources, however we can in that first phase. The intervention phase is where we are working with that person living with dementia and engaging them in self-care tasks, cognitive therapy activities, and specifically things that they enjoy and find purposeful. So we kind of tailor activities to where they're able to and what they enjoy, and specifically looking at that cognitive level and challenge them, give them the just right challenge. Because we also know that activity engagement reduces dementia behaviors and improves the quality of life with the person with dementia. Also in the intervention phase, we educate the care partner on strategies for better communication, environmental strategies. And then finally we have the generalization phase, and in that phase, that is where we are kind of going over all the strategies we've taught the caregiver, and teaching them how to generalize these strategies to future problems and things that may arise in the future for the person living with dementia.
With COPE being care partner centered, we just want to be sure that we are providing any kind of education and strategies as to why the person with dementia is doing what they're doing or behaving that way or not communicating like they used to. And I think for us as well as therapists, we have to step back, because something that we might see as a priority and want to address, we need to put that aside and remember it's what the care partner is seeing as the priority and wants the education and the help with.
COPE is more so for those with more behavioral challenges, or they're starting to have more difficulty with some of those self-care tasks, their day-to-day tasks, where cognitive stimulation therapy is more like mild to maybe that moderate level.
Cognitive STEM is there's 14 sessions, and they get progressively more difficult as you go through them. And then they're all themed so that you get different people have different interests. So you hope within the 14 everybody gets something that they like out of it. We have seen here really good results. We see depression scores go down, quality of life goes up, their perception of their quality of life, which correlates with cognition, and we see their cognitive scores go up. We pre and post test everybody. Initially we just did cognitive STEM. And then as we ended the groups, no one wanted to quit coming, so she rolled them into maintenance. So those people come once a week because they don't want to stop coming because they feel the benefit.
I think it helps me keep more alert and active, and helps me keep my thought process good. Helps me stay a little younger in my heart, I guess. It's good for me, keeps me moving. Gotta keep our bodies moving and keep our mind active and filled with happy things.
We are very unique in that when we're screening, because part of that screening process is for sarcopenia and frailty. And when we're screening for those, I mean, we get people into skilled physical therapy, but what we know about that is that it's very short-lived. People go in, they do physical therapy, and then they go back home and they stop, and then they just regress. So what we've created here is we actually have a certified personal trainer that we've trained in. She's trained in cognitive stimulation therapy, and also has developed an exercise program, also done in a group setting, which is fun. It's it's a progressive, working on balance, particularly in balance and just endurance. So that's long term.
Now the studies are showing exercise really benefits cognition. So a lot of times they'll come in and they'll have, maybe 45 minutes to an hour of CST, but they also get 20 minutes of exercise. And so we also watch those measures. We watch how well their strength is, how well they're moving, how well their walking is, and all those measures always improve over the 14 sessions.
We want to use physical movement as an essential component for this program. And so with that, I've devised an exercise component that's about 20 minutes long that we do once a week in our maintenance classes. And it focuses on foundational exercises, basic movement patterns, just teaching people proper movement, working on balance and leg strength, and all of those things that are just going to increase mobility and independence, allow people to do their activities of daily living, and just improve quality of life.
I enjoy being with the women, and it's just a good place to come.
Our biggest goal is safety, but we want to incorporate exercises that are going to work balance, that are going to work leg strength, and again, just kind of keep people mobile and independent as long as possible. Things that will translate into their everyday life.
Both CST and COPE are very age-friendly programs. The interprofessional approach is key because you've got social work, you've got OT, you've got speech, and those three disciplines come together, and they all have different backgrounds and maybe a different perspective on things, but as long as we all collaborate and work together and we interact and keep the caregivers and the patients as our center of focus, then that will be hugely beneficial to those families.
And so as part of that is this model of the 4 M's. And the first M is what matters. So really asking older adults what matters to them, because what matters to us and what we want from them is very different than maybe what they want. And oftentimes what matters to them is staying mobile and being able to remain in their own homes. And I think that is really the mission, our goal for the entire older adult population, is keeping our older adults, improving their quality of life and keeping them in their own homes for as long as we possibly can. And also we're looking at medications. So of course, reducing the number of medications that patients are on. So our physicians are all great about that. So we really want to get those medications down, particularly any medicines that are affecting their mobility or their mental status. And as far as mentation, we also have a licensed clinical social worker who goes into patients' homes to do counseling and also into long-term care setting, which is very much a neglected population of people with depression.
Our designation as an age-friendly healthcare system has caused an increased awareness in our organization for the geriatric population and the needs thereof. I believe that our goal as a health system, and as every other health system's goal, is to, again, support all aspects of life. And this is a program that has done great things for our elderly population, and sometimes that population can be overlooked. So I think it's important that other administrators consider all aspects of care, all aspects of life, and look to a program like this to help support that population. We take a large amount of pride of having this program in our health system. And we've had numerous visitors from all over the state, the region, come in to see this program to hope to try to emulate it within their communities and bring that type of support back to their populations as well. So we've been honored to be a part in a kind of a site for people to come and see our program.
When caring for this population, older population of people, it cannot just be the primary care physicians. I mean, it's really a team approach. The reason for the whole geriatric workforce enhancement project is to train healthcare professionals across the spectrum in recognizing those geriatric syndromes. But not just recognizing them, but having a system of having those interventions and that algorithm approach to treating and following these patients through the system.
Well, my mom was diagnosed almost 2 years ago, and early Alzheimer's. She's been in the CST group for about 1.5 years now, and I feel like it has helped in many ways, especially just kind of, if nothing else, delaying the process a little bit more. And even her neurologist has commented too that this is the best thing we could be doing for her, is just the mental stimulation and the physical stimulation. And it's just, CST has been an amazing resource for her. People should know this is out there, because I mean, Alzheimer's, it's a scary road for the patient, but it's a scary road for the caregiver too, because you're kind of watching this family member gradually slip away. And this group just kind of helps to maybe delay that process a little bit and just gives you that resource. And if more people were aware of this, I think it would be hugely beneficial, because it just, I don't know, it gives you a place to go to, a place to turn to if nothing else, and it helps. It helps the whole family. It's just been a joy and a pleasure to hear people's stories, because it's particularly with CST, you get, it's about taking them from their past and bringing those memories forward and making those new connections. And so just being able to be a part of that and watching them, they just have such joy. I mean, it's a lot of fun. They're just in a comfortable, safe environment with other people who are struggling in similar ways. My important mission is to be able to help other hospitals and healthcare systems develop similar programs like this.
As you have learned, transforming organizations into an age-friendly health system is a team effort. It really does take a village. What can you do to begin the process? Visit the Institute for Healthcare Improvement's Age-Friendly Health System website to learn more about the process of transformation. This site includes a number of resources that you will find helpful in creating an age-friendly setting. The process of shifting to an age-friendly health system involves the following: assessing your current state, specifically, what are your practices in providing care to older adults and their care partners? Again, the Institute for Healthcare Improvement website includes a number of resources to aid you in your organizational assessment. Describing care consistent with the 4 M's and how that may look within your organization is the next step. Designing or adapting your workflow to include the 4 M's at regular intervals, which may include a new patient visit the yearly Medicare annual wellness visit, or if there's been a change in the older adult's health or life situation. Introducing the 4Ms into your health record system so that your staff can provide care by assessing each older adult using the 4Ms and incorporating the 4Ms into the plan of care. Studying your performance so that you can routinely modify workflow practices. Improving and sustaining care. Finally, consider also applying for age-friendly health system recognition through the Institute for Healthcare Improvement. Our team here at St. Louis University has developed expertise and resources to support organizations through a transformation. If you would like to learn more about becoming age-friendly, please visit our website or contact the Gateway Geriatric Education Center. We are ready to help you in your journey to providing quality care to older adults and their care partners.